The Asia Ventilation Forum is a not-for-profit organization with members from 8 different Asian countries, sharing knowledge and experience in respiratory care and critical care with ICU workers across the continent with the aim of improving care and outcomes for the critically ill. This edition of the podcast is about ICU tips and tricks, and today's topic is about airway management in the context of the COVID-19 pandemic. I am your host, Jeb Palo from the Philippines, and with me is Professor Sheila Myatra of the Department of Anesthesiology, Critical Care and Pain of Tata Memorial Hospital in Mumbai. She is the president of the All India Difficult Airway Association and a main author of the Difficult Airway Guidelines for the ICU developed by that association. Hi, Sheila. It is a great pleasure to speak with you virtually.
Hello, Jeff. Indeed, a great pleasure to have the opportunity to speak on this podcast of the Asia Ventilation Forum and have the opportunity to interact with you. Thank you.
So, airway management is a critical component of care in critical COVID-19 disease and also represents the highest risks to our own staff. Since it has many aspects, I think we can discuss this in phases, and I guess we can start with how you and your teams prepare yourselves for an airway emergency in this pandemic period.
Thank you very much, Jeb. I think this is a very relevant question because we first need to understand what are the complexities, the differences and the challenges in order to be prepared better for airway management. As you know, tracheal intubation in ICU itself is a high-risk procedure. Recently, we had the Intube study, which I was a part of, which was published in JAMA, which showed that the complications related to tracheal intubation, and this is in non-COVID, itself is as high as 45%. Almost 1 in 2 patients have a complication. So this is in non-COVID patients. And now we have a new situation where we are intubating patients with COVID-19. So the complexities in this are multifold. First of all along, we've always been concerned about patient safety. First pass intubation success, getting the tube in, oxygenating the patient, ventilating them right. For the first time, we had to actually also worry about the healthcare worker and especially the airway operator safety. So the problem became twofold. So not only were we concerned about the patient safety, but also to limit the transmission of the virus. So this made airway management, which was already a high-risk procedure in ICU, even more challenging. And if you ask me, to avoid the transmission of the virus, we were wearing personal protective equipment. If you just look at the PPE, and I'm sure everyone knows how difficult it is to work with the PPE. Not only is it uncomfortable, but you have the face shield, you have the eye protection, there's a lot of fogging, which reduces your visibility. In addition to this, it's very uncomfortable. And one of the most difficult things is the communication. It was very difficult to communicate with your team. So if there's any problem or you need some additional equipment or you need to, say something needs to be changed, it became very, very challenging. So working with the personal protective equipment. In addition, especially in the beginning of the pandemic, because of the fear of transmission of the virus to the healthcare workers, we were limiting the number of staff that were actually going in for the tracheal intubation, unlike in earlier times. So very often we would try for 2, but sometimes it would even be 1 person. Again, staff availability was an issue, and we wanted to avoid the risk of exposure. So in this sense itself, having 1 experienced staff and even number of people available to help during airway management became a challenge. In addition to this, specific precautions had to be taken in the beginning, and I'll talk a lot about that later, about intubation boxes, about using tents, etc. So a lot of unfamiliar kind of equipment was being used, which made airway management even more challenging. So this was the kind of background, and it all stemmed from not only ensuring patient safety, but also healthcare worker safety. And this made an already high-risk procedure in ICU even more challenging.
So thank you for painting a good picture of and painting the context for our listeners regarding the challenges of airway management. Regarding the procedure itself, regarding the preparatory phase all the way through the procedure, could you walk us through how your practice has changed over the last year and a half?
Right. Thank you, Jep. I think this question is really relevant because we were caught unawares. We had very limited time. We had no literature or no evidence or studies to tell us that this approach is better than this approach. So, to be honest, the airway management practices actually evolved through the pandemic. And we learned from our mistakes, then we learned from subsequent studies. But definitely, as I mentioned earlier, there were concerns about transmission to the healthcare worker. So we had to be very careful about where we were doing. We had to even think about where are we doing this procedure. Should we be doing it, in one cubicle or in open space, or where are we going to do this procedure? So from our data from non-COVID, other infectious airborne diseases, we were looking at negative pressure rooms. So a lot of, so negative pressure rooms will help you contain the virus because of the negative pressure. It will prevent the transmission outside the room. So it will protect the healthcare worker outside the room when we do tracheal intubation. And tracheal intubation was considered as one of the very high risk procedures for aerosol generation. So this became a big concern. You're doing this very high risk procedure. There are a lot of healthcare workers around. So what is the ideal environment that you should have? So ideally, we should have a negative pressure room. But I'm sure you're aware it is not easy, even in the developed world, to have negative pressure rooms for every intubation. So a lot of units were intubating in the negative pressure room and probably transferring the patients outside. Rooms that didn't have it, of course, this was not possible, but that is the ideal setting. But more important than the negative pressure room was the actual air changes. So this is very important because for every air change, you reduce the viral load by 63%. So you need at least 5 to 6 air changes to reduce the air changes to less than 1%. So a lot of units had structural, tried to increase the air changes so that there would be more clearance in the environment. So these were some of the kind of structural changes, and you can't make negative pressure rooms overnight, but people were looking at increasing air changes. And this was not only in the intensive care unit, but also in the operating room. Of course, where this was not possible, intubation was done in the individual cubicles, and we tried to wear the best possible personal protective equipment. But even this was a shortage in the beginning of the pandemic. So the first thing is, where are you going to do the tracheal intubation? Ideal would have been a negative pressure room, but wherever you are, make sure that your staff is protected. One of the most important aspects is the team preparation. And I realized this even more, the value and importance of team preparation during COVID. As I mentioned, the challenges of using a PPE and communicating. So important to have your team, and the team of course can't be a big team because you have to limit the number of healthcare airway operators that you're going to use, because again you don't want to expose more people. So we try at least for 2 people, and one should definitely be an experienced airway operator. Yes. Because this is very important for first pass intubation success. So you limit the time of the exposure to the healthcare worker. So team preparation is very important because you need to decide as to what are you going to do, how are you going to do this intubation, what drugs are you going to use, what is the procedure. If it fails, what is your rescue plan, what is your backup plan, and who is going to get what. And if you need more equipment, because all equipment would not be kept around the patient because we don't want to contaminate everything. So who would be the runner, who would go outside and pick up. So this entire planning and communication, including sign language. So we also had, some signages because it was very difficult to communicate. So this all had to be done before we actually started. So the complete preparation, and in terms of equipment that we needed, definitely even units which were using direct laryngoscopy moved to using video laryngoscopy, because for 2 reasons. One, because of increased first pass success, and secondly, for keeping your face away from the oral cavity, because you're looking at the screen rather than looking into the, going into closer to the mouth when you're doing a direct laryngoscopy. So keeping video laryngoscopy ready. In addition to that, we had to use 2 heat HME or viral filters. So one would be between the mask and the ventilator circuit, and the second would be between the expiratory limb and the ventilator. So we had to make sure we had this available. Most units, of course, are routinely using it, but many units who didn't had to start units using it. And definitely a big no-no for open suction. So we had to have the closed suction ready to connect immediately because this patient is going to be ventilated for long. So in terms of preparation, where are you going to do the intubation? Who are the personnel involved? what is your team structure and communication and the plan with the team, and third most important, what is the equipment that you're going to be requiring, and is all that ready? So this was a big difference from the routine other tracheal intubation that we would do in critically ill patients, where we could take some time, we could get some help, we could have more people, we could have someone running and getting the equipment. So all this had to be properly planned, and this was a big difference with the airway management in COVID-19 patients.
So the importance of planning the space, planning the people, making sure that you had the least amount of time exposed to the patient. These were all very important aspects. So you mentioned actually how important it was to minimize the exposure of the healthcare workers. And there was a lot of concern earlier on about non-invasive ventilation, the use of high flow, as methods of pre-oxygenating our patients, including actually bag mask ventilation. So how has this practice evolved over the last 1.5 years for you and your team?
Thank you, Jeb. This is actually an area in airway management that has really evolved over time through the pandemic. So initially, the fear of the aerosol generation with non-invasive ventilation, as well as high-flow nasal cannula oxygen, limited the use of both of these, not only in patients presenting with acute hypoxemic respiratory failure, but even as pre-oxygenation for tracheal intubation. Now, in the non-COVID era, if we had high-risk patients, with very who are very hypoxic, with low P2F ratio, we would use high flow nasal cannula oxygen, or we would give NIV for pre-oxygenation so that we can use pressure support along with PEEP and give them a little better pre-oxygenation. And if we pre-oxygenated with HFNO, then we would continue this during attempts at intubation in order to prolong the safe apnea time. So this was our routine practice in ICU, because we know these are not the patients with normal lungs. These are high-risk patients that we are intubating, so we want to pre-oxygenate them well so that we can prolong the safe apnea time. Now, during COVID, this really became a challenge because everyone was worried about this aerosol generation, and we, didn't, in the beginning of the pandemic, no one was using high flow and NIV, and we were just using the conventional oxygen therapy for pre-oxygenating. Even in non-COVID patients, though we give rapid sequence intubation, in high-risk patients or those who are at a risk of desaturation, we do give gentle mask ventilation now, because the risk of hypoxia exceeds the perceived risk of aspiration due to bag mask ventilation. Even this practice stopped completely because people said no mask ventilation, because mask ventilation will cause aerosol generation. So it was just conventional oxygen therapy, rapid sequence intubation, no high flow, no NIV, and no mask ventilation until the tube was in and the cuff was secured. But over time, what happened is we realized that we need to use these techniques because this is safer for the patient. And in addition to that, there was increased availability of PPE. And we realized that the most important intervention to protect the healthcare worker is to make sure he was adequately geared with his personal protective equipment, because the evidence was evolving. So initially it was thought that high flow nasal cannula oxygen and NIV was aerosol generating. In fact, tracheal intubation was considered as the most highest aerosol generating procedures. And we had a publication in Anesthesia last year that clearly showed that a single cough actually generates much more aerosol than tracheal intubation itself. So aerosol generation with tracheal intubation and extubation was actually questioned, that if you give muscle relaxant to this patient, does it really produce aerosols? And this kind of changed the way we were practicing. So I would say in the beginning of the pandemic, we were very careful with our pre-oxygenation. We were using conventional oxygen therapy and no mask ventilation at all during RSI. But over time, what we've started doing now, we've started using HFNO and NIV for pre-oxygenating high-risk patients. And in those who are at a risk for desaturation, we've actually started doing gentle mask ventilation, and keeping in mind that wearing your PPE and being adequately geared is paramount to protect the healthcare worker. So in short, we do what is best for the patient. We do what we're routinely doing, but at the same time, we protect the airway operator appropriately.
Right. So you did mention earlier on about the use of rapid sequence intubation a lot. it was funny that we found that in a lot of places, actually, in my own country, for example, that they weren't actually used to doing neuromuscular blockade prior to intubation. So that leads to my next question about the best practices in your mind regarding the pre-medications and basically the all the way through the intubation procedure. If you could walk us through what you do and what your team does.
Right. So not only because of fear of the aerosol generation and the exposure, but even otherwise in non-COVID patients, rapid sequence intubation has been found to be associated with less complications. So the routine practice would be to give some opioid or benzodiazepine along with ketamine or etomidate, because a lot of the critically ill patients, hypotension is a big concern. They are usually intravascularly depleted. They may be in shock, and they can have precipitous fall in blood pressure when you give propofol to these patients. Another issue is that they have high sympathetic drive, and the moment you anesthetize them, the blood pressure kind of drops.
Thanks.
And even after you intubate them, because of the hypovolemia, when you give positive pressure ventilation, this can further compound the hypotension. And this has been very well demonstrated in the recent Intube study that was published in JAMA, which showed that the incidence of hypotension is actually higher than the incidence of hypoxia in intubation in critically ill patients. But in COVID, what we were seeing is that the hypoxia was profound.
The major problem.
Yeah, these patients were relatively cardiostable. Of course, there were always exceptions, but we found that hemodynamic instability really wasn't so much of a problem as the hypoxia. So a lot of units actually used propofol. So the practice would be ketamine and etomidate if you were worried about the hemodynamics. Otherwise, propofol was also more used, I would say, during the pandemic. And rapid sequence intubation was practice, and this would mean pre-oxygenation, as I have described, and giving ketamine. Regarding neuromuscular blockade, again, you don't want spontaneous breathing, and the thing was that you give muscle relaxant, and this will not only increase your chance of first pass intubation success and decrease the complications, but also decrease the risk of aerosol generation and exposure to the healthcare worker. So the drugs that were used were suxamethonium, if not contraindicated, and rocuronium. Again, here a word about rocuronium. If you want to get intubation conditions very quickly, like in 60 seconds, then you have to use much higher doses of rocuronium. So we're talking about 1.2 milligram per kg of rocuronium should be used. So the practice was, pre-oxygenation. In the beginning of the pandemic, we were using a good seal of the mask while we were pre-oxygenating. And one of the things that we started to do is we started to look at capnography during pre-intubation. So right. So this is one way. You have a good capnographic waveform, and this shows you that the leaks are minimal. So we were holding the mask tight, and I found capnography was very useful for pre-oxygenation. And then we would obviously give our drugs. Ketamine, etomidate was one of the two, which is more cardiostable. But some people were using propofol, followed by suxamethonium or rocuronium, and then doing a rapid sequence intubation, not ventilating. However, in patients who were at risk of desaturating, very hypoxic patients, or if they actually desaturated, then we were giving gentle mask ventilation a little later in the pandemic. And what we did differently, as I mentioned earlier, we used 2 HME filters, the viral filters. So as soon as the tube was in, we would inflate the cuff and immediately attach the viral filters. For tracheal intubation, we were using video laryngoscope. Even units who use direct laryngoscopy were preferring video laryngoscopy. And this was for 2 reasons. One is to increase the chance of first pass success. And secondly was to decrease, the exposure to the healthcare worker, because you're looking away, you're looking at the screen, you're not going into looking into the oral cavity. So this was one area where video laryngoscopy definitely scored better than direct laryngoscopy. Though this has not been studied, there has been no RCT comparing the two in the ICU in COVID patients yet. But definitely it made more sense to use video laryngoscopy. And after tracheal intubation, the most important thing was to confirm the tube position using waveform capnography. We inflate the cuff first. We immediately attach the viral filters. And we use closed suction. This was very important because this is not a patient like in the operating room where you're going to extubate in a few hours, likely to need repeated suction. So even units who are using open suctioning in some places in the developing world had moved to using closed suction system to avoid exposure to the healthcare worker during suctioning. So this was just about the actual procedure of intubation. Of course, early in the pandemic, we were also using intubation boxes, and there were also some sheets. I can talk about that later. But this was something we were unfamiliar with. This definitely made intubation more challenging, and one had to practice a lot with mannequins and in routine non-COVID patients before using this in the intensive care unit. So this was an additional, kind of thing that we were using during tracheal intubation.
So regarding those, actually, I'd like to speak a little bit about those adjuncts or those barriers, actually. I remember they were very much in vogue in the beginning of the pandemic when very little was known. And so everybody was building these and giving them to hospitals. And by a few months later, they were just piling up everywhere in the corridors.
Right.
What was your experience regarding that?
Yes, absolutely. They're all piled up in one corner at the moment, and we're not using it. But I think, people were very afraid, right? So it played on the kind of fear that people had. And in addition to this, it was logical. It made sense, You have to do airway management. Whoever thought of it, I mean, it seemed like a smart idea because you have a fear of, firstly, it was thought to be droplet. Later, they said this is aerosol, tracheal intubation is aerosol generating. So they were worried. So if you have some kind of barrier and you have some space for your hands to go in and do tracheal intubation, then why not? It seemed logical. And what happened is, there was a lot of innovation. That should you have a sloping top? Should you have a flat top? How would you increase the visibility? And of course, a lot of innovation. And there was so much discussion on social media and widely across the globe. People were making different types of tents with negative suction. We were having intubation boxes. People were using sheets. In fact, the discussion was so much that this became more viral than the virus itself. This whole talk about the intubation boxes and make sense. And we had no data to support its use or to this thing. But I'm sure, and I'm sure you agree with me, but every airway operator who is using these intubation boxes, they found tracheal intubation difficult. Firstly, they were unfamiliar with this. It made the intubation more difficult. It restricted your hand movements.
Your approach.
And I was very unhappy using it, and there was no benefit, evidence of any pair innovation. But fortunately, we had publications, and this came in anesthesia last year, and we had some very good papers which actually showed that there was firstly no benefit. In fact, there was more harm because people were unfamiliar with this. They were, doing this for the first time, using the, not very, this was not routine airway management, restricted their movement. It made intubation difficult. In addition to this, they also found PPE to tear. So this again increased the risk of exposure to the healthcare worker. So the risk was more. If you look at the benefit, definitely it was a barrier. So maybe it protected the healthcare worker against droplets, but there was a concentration of the aerosol, especially when the patient coughed under that. The moment you remove the box, there was a big exposure to the healthcare worker. So it was actually considered dangerous. And subsequently, there was a very nice review that was published in the British Journal of Anesthesia, where the authors recommended that until we have further evidence demonstrating the safety of this, these intubation boxes actually make intubation difficult, and we should avoid using this. And then gradually over time, during the pandemic, people started, limiting the use. And then I think across the world, I'm not sure about where you work, but we have stopped using it, and they're all piled up in some corner in the hospital.
That's what happened. But regarding the other innovations, since the world was learning about how to most safely perform these procedures all at the same time, and so there's a lot of sharing online and social media. So we are at the tips and tricks portion of our podcast. What were your favorite innovations that you have adopted, and basically are still using today when it comes to airway management?
So actually, it's interesting you ask me this because, to be honest, the one tip and trick I learned over time is not to have any additional tips and tricks, to do exactly what you do.
I like that.
You do during routine airway management, what you're most familiar with, just do that, but be protected. Of course, you have to wear your N95. You have to be adequately protected. We don't know. The evidence is evolving. Is it aerosol generating? Is it just droplet? What is the exposure? I mean, we're going back and forth with the literature. But until then, I think we should be well protected while doing a potentially aerosol generating procedure, as we call it. So I would say the one thing that I learned was that don't do all these things that are different from your routine practice. Just stick to your routine practices that you're very good at and what you're routinely doing, what your team is familiar with, but just stay protected. One thing I can tell you that I was doing is this thing about, using capnography before tracheal intubation with the mask. So that really helped because I was sure that when I saw good waveform capnography, it gave me more confidence that there's not much leak.
No leak.
So I would also adjust my last mask position based on that. So these kind of small things, and even if I didn't keep too many people inside the area where I was doing the tracheal intubation, we had someone ready just outside, so we would keep them outside the room and they would be ready to come in case there was a problem. Developing this kind of sign language really helped, and over time, this communication. So these are some of the things that you have to work around with your team. But I would say that over time, seeing especially the way the intubation boxes and all this has panned out, I really feel sticking to the basics, doing what you do routinely, sticking to standard airway management practices is paramount for patient safety. But of course, you need to protect yourself adequately with appropriate PPE.
So thank you for sharing those tips and tricks with us. But when we're talking about complication rates and the importance of first pass success rates, is there anything that you can tell us about how to improve ourselves when it comes to those aspects?
Right. Thank you for asking this question, Jeb. In fact, I'm very happy to say that just this month in anesthesiology, we've published a global study looking at prospective tracheal intubations in almost 4,500 tracheal intubations that were done in COVID-19 patients. So we actually have data to share with you about the experiences and the complications that occurred during tracheal intubation, and especially about first pass success that you asked me about. Now, definitely, everything that we're doing in COVID to limit the exposure to the healthcare worker, we want to have first pass success. We want to, limit the time between that the healthcare workers are spending around the patient before the tube actually goes in. And for this, we have to ensure that the patient has, we don't have multiple attempts at intubation. And in these close to 4,500 patients, and this was from 32 countries across the globe. So this was done very quickly in a short period, almost 6 to 7 months, where people prospectively entered their data and this was shared and analyzed. And they found that the incidence of first pass success rate was as high as 89%. So that is pretty good. And there were only 10 patients who actually, among these close to 4,500 patients who required a surgical airway. And very few patients who went beyond, up to a third or fourth attempt at intubation. So this obviously means that people realize the importance of first pass intubation success. They were using more experienced operators for doing tracheal intubation because of the risk of aerosol, and more use of video laryngoscopy. Now, multivariate analysis that was done on this data actually showed that rapid sequence intubation versus not using rapid sequence intubation definitely increased the chance of first pass success. And in addition to this, also having an experienced operator made a lot of difference. So that seems obvious, but I think in these high-risk intubations, where you're not only worried about patient safety, but operator safety is also paramount, I think it's important to have an experienced operator doing the tracheal intubation. Of course, you can't get the most experienced one, but in your team, whoever is most experienced available at that time should do the tracheal intubation. And I'd also like to say that many hospitals worldwide, especially during the pandemic, they had special intubation teams. So this was something that was very useful, because rather than expose a lot of people, and you just have a team and they just go in, put in the tube, do this high risk procedure for you, and they come out, and the patient is managed by somebody else. So definitely in this kind of pandemic situation, perhaps having intubation teams can increase the first pass intubation success, since it's been shown that the experience of the operator makes a difference. So I thought I should share this information with you.
Well, thank you very much for that. Well, we have covered so much material, and I think it was more proper actually for a whole workshop rather than just a short podcast. But unfortunately, we have a limited time. So I really want to thank you again, Professor Myatra, for sharing your expertise with us. So today we have spoken about airway management within the COVID-19 pandemic. And again, this was a short podcast with Professor Myatra of Mumbai. Thank you for listening. Until next time, this has been the Asian Ventilation Forum's ICU Tips and Tricks podcast. Thank you for listening.
Thank you so much, Dr. Jeff. Thank you.